This line graph tracks the diagnostic volume for oncology in the United States. The trajectory crosses 2 million new cases in 2024 and points directly to 2,041,910 projected diagnoses in 2025. The curve shows no sign of plateauing. These numbers dictate the physical reality of running a practice. Every new case represents a structural demand that your clinical and administrative teams must absorb. While patient volume scales upward, the internal capacity of the workforce handling that volume is fracturing. Burnout rates among oncologists have climbed sharply over the last decade. By 2023, 59% of U.S.-based oncologists reported symptoms of burnout. That is a 14-point jump from 2013. When surveyed, physicians point to a specific cause. The primary driver of this exhaustion is not the clinical complexity of treating cancer. It is the administrative burden pulling them away from their patients. We call this administrative friction. It's the constant drag of paperwork, of data entry and phone calls that silently erodes your clinic's capacity to deliver care. With administrative friction scaling alongside patient volume, the traditional oncology practice model faces a structural breaking point where administrative requirements exceed operational capacity. Within this friction, prior authorization is the most acute point of administrative failure. This chart breaks down exactly how severe the problem has become. 83% of surveyed radiation oncologists report that their prior authorization burden has worsened in the last 3 years. In community practice, 60% of all cases now require it. Transformed into operational time, practices average 43 authorization requests weekly, consuming 12 hours of staff time. When peer-to-peer review is mandated, a single authorization event drains up to 95 minutes of physician time. The burden bleeds over into the patient experience. 3 out of 4 patients must navigate the prior authorization process, and in half of those cases, families are forced to actively intervene themselves. This friction stops treatment. Over 90% of surveyed oncologists report that prior authorization caused delays, with most of those delays lasting 5 days or longer. The clinical data from ASCO shows the ultimate cost of those delays. 30% of oncologists reported major complications, and 7% linked prior authorization directly to patient deaths. Health insurers originally designed prior authorization to control costs. In an oncology setting, it functions as an aggressive operational bottleneck. The cumulative effect of these requirements transforms prior authorization into a systemic barrier that delays care and disrupts clinic operations. The traditional response from practice owners is to hire more in-house administrative staff to clear the queue. That solution ignores the reality of the current labor market. MGMA data characterizes this as a structural reset, with managed care administrative wages rising 39.1% over the last decade. Compensation is only a secondary issue. 53% of practice leaders cite simply finding candidates at all as their top operational challenge. Even when practices secure talent, they face a retention crisis. Annual turnover for front office support roles now runs between 30 and 40%. This cyclical flowchart maps the financial drain of that turnover. Replacing a $40,000 employee costs between $20,000 and $30,000. That covers the 6 to 9 months of lost productivity required to recruit, onboard, and retrain a replacement. Practices cycle through this process multiple times a year. It bleeds revenue without ever permanently clearing the authorization backlog. When a front office specialist leaves, the unfiled appeals and paperwork immediately flow downstream onto the attending physician, intensifying the burnout cycle. The high turnover hiring model creates a financial drain that prevents clinics from reaching operational equilibrium. Relying on generic administrative staff relies on a false assumption, the idea that standard healthcare administrative experience translates to oncology. This workflow map illustrates the demands of a single new patient. The intake process branches out into insurance verification, diagnostic prior authorization, chemotherapy authorization, scheduling across multiple providers, lab coordination, and financial counseling. This workload is compounded by constantly changing payer requirements and strict step therapy protocols for new biologics. Data from MD Anderson's specialty pharmacy proves the scale. They processed nearly 6,000 prior authorizations in a single year, resulting in an outright denial rate of 16%. Fighting a single denial demands intense manual labor. A staff member must call the payer, draft an appeal, gather clinical notes, and track the outcome across completely disconnected software systems. Oncology administration is a highly specialized discipline. It breaks unspecialized two-person front desks. Analysis from ASCO's Steps Forward program and the MGMA identifies a specific evidence base for operational success: automated workflows, dedicated role ownership, and the separation of clinical and administrative tasks. Practices are achieving this through systemic arbitrage, utilizing dedicated EHR-native virtual medical assistants. The VMA model supplies offshore oncology-trained teams that integrate directly into the practice's native software, delivering 45 hours of dedicated weekly coverage. This comparison reveals the financial reality. An in-house employee costs $60,800, factoring salary, benefits, turnover, and overhead. The VMA model operates at a flat $21,600. That difference strips away $39,200, delivering a 64% cost reduction. The VMA system eliminates the hidden costs of the staffing spiral entirely. Backup coverage, ongoing training, and management are all included in that flat rate. It operates on an enterprise-grade compliance infrastructure, carrying full HIPAA, SOC 2 Type 2, ISO 27001, and HITRUST certifications. The VMA model transitions a practice away from fragile, expensive human bottlenecks toward a resilient, predictable operational engine. Artificial intelligence augments the human workforce to maintain a sub-1% error rate by utilizing automated verification and anomaly detection. Intelligent task routing assigns workflows to specialized team members. Machine learning flags data anomalies, and predictive forecasting anticipates volume spikes before they become compliance issues. Implementation is aggressive. Practices go live in 48 to 72 hours, connecting the remote team directly to existing EHR protocols. Over time, the dedicated, non-rotating team builds institutional knowledge. They learn your specific formularies and provider preferences, which directly drives down denial rates. Administrative bottlenecks of this scale indicate an architectural failure in the practice model, triggered when administrative tasks consume more than 30